Good morning. We're doing another video and we're going to talk about when do you start dialysis. This question gets asked a lot by patients and by primary care providers. I am Dr. James Hall. I'm a nephrologist, been practicing for about 20 years, and we're going to talk about some of the ramifications surrounding when your patient goes on dialysis. When do you actually start dialysis? Ultimately, Medicare will pay for you to get dialysis when your kidney function is below 15%. So that's when we typically start dialysis. Now, sometimes if a patient is uremic and they're really sick from end-stage kidney disease and a GFR 16, sometimes we'll start a patient at a GFR 16, but 15 milliliters per minute is the cutoff, and that's what we always try to prepare for. Meaning, the closer we get to 15 milliliters per minute, the more we want to make sure the patient has an AV fistula, a PD catheter, or an AV graft in place so that we can start dialysis and the transition will be easy. Most patients who are diabetic, their kidney function will ride along in stage 4, and at some point in time it seems to just drop off the cliff, and that's kind of that danger zone that we don't like, because those patients usually don't do well because their kidney function is so advanced. They have an advanced diabetic glomerulosclerosis, and it drops their GFR precipitously. And so a lot of times we're just pulling straws trying to quickly get them on dialysis. And unfortunately, a lot of them have to get a tonal catheter, a dialysis catheter. So when patients' kidney functions get to around 18 milliliters per minute, that's when we really start to push access. We start to push CKD education. We start to push all the things that will prepare them for getting on dialysis. I give you a little case report. We saw a patient this morning. Her kidney function was dropping nicely, or not nicely, however you want to look at it. And it was down to 17 milliliters per minute. So we referred her for a buried PD catheter. Typically, that's what we like, is to get the catheter buried under the skin. If you'll think about it, we'll put the catheter up under the skin and it's in place. You can't see it, but it's already there and ready to be used. When the kidney function gets below 15, we will externalize that PD catheter and start using it for dialysis. So that's how we approach patients who are kind of pre-ESRD. They're not at a point where they need dialysis, but they're really close. We'll get a buried PD catheter in. We'll bury it under the skin and leave it in place however long it needs to be. I've had patients with a catheter like that for years, and then whenever it's time to start dialysis, the surgeon will externalize it on an outpatient basis, and we'll start dialysis without the patient even having to go in the hospital. Medicare and all the insurance providers are pushing outpatient dialysis starts. So we're pushing outpatient dialysis starts because patients seem to do better. They don't flood the hospital. The nursing staff is not flooded. And it seems to be the best transition for our patients. So if you're a primary provider, what do you need to know? You need to make sure that your patients are attending all their appointments and make sure that they're following up and asking the right questions. That's the main thing that I recommend, is patients should always ask the right questions. There's a lot of ignorance because patients aren't doctors and nurse practitioners and physician assistants, so they just don't know. But as a provider, our job is to bridge that gap. Bridge the gap from knowledge to letting patients know what's going on in their language, layman's term. Speaking of bridging the gap, I created this YouTube program and this course to try to bridge the gap from medical knowledge to clinical practice and help you as a primary provider make the connection of what you've learned in school and how to apply it in your clinic. So check out our free webinar below in our community. Ultimately, I want you guys to be able to know what we do behind the scenes, know how we manage patients in the nephrology setting, so you can tell patients what they need to know in your clinic. So patients at 18 need to be sent for an access, either a fistula or a PD catheter. If they're not where we need to start peritoneal dialysis urgently, we will get the catheter buried under the skin. We'll embed it under the skin so that it's available and ready when it's time to be used. If the patient's at a point where they got to start, we'll get a PD catheter put in and start them up. Usually it takes about a month for that catheter to heal up. I have a patient in the hospital now. We put a PD catheter in yesterday, and we're starting peritoneal dialysis today because we don't have a month to wait. AV fistulas and AV grafts usually take about 2 to 3 months to heal up. So we try to anticipate and get our ducks in a row so that when it's time to start dialysis, the access will be in place. Now, what about tonal catheters? We absolutely hate tonal dialysis catheters. Tonal dialysis catheters are tonal under the skin into the jugular vein. Usually it's the right jugular vein. And my right is here. I know it looks like your left, but my right is here. We usually like the right jugular vein, and that's where the tonal dialysis catheters are placed. Some people call them ash split, but ultimately these catheters cause a lot of problems. They are the second most common cause of death in dialysis patients. Tonal dialysis catheters are the second most common cause of death in dialysis patients. That's why we hate them. They cause central vein stenosis in your subclavian vein, in your jugular vein. They cause clots, thromboses. They cause catheter infections, septic emboli, and they are bad news. Endocarditis. We hate those catheters. But if a patient urgently needs dialysis, what options do we have? We have to put one in to give them dialysis. So please advise your patients to try to get their access in place before they get to stage 5, 15% GFR. Because you don't want these catheters. They're just bad news. They're inconvenient. You can't swim. It's a lot of other complications from those catheters that we hate. So I advise you to talk to your patients about access, talk to them about dialysis catheters, talk to them about timing, and talk to them about the advantages of home dialysis. Home dialysis is the way to go. The jury is back. The verdict is out. We know home dialysis is the best treatment for a dialysis patient, second to getting a kidney transplant. So advise your patients on this. So when do we start dialysis? When the kidney function is less than 15. 10 to 15, sometimes it's a gray area. Patients can do really well, and their albumin and their electrolytes can be normal. But we know that they're going to be needing dialysis soon. So less than 15 is our cutoff. Thank you for listening to this video. Check out our next one. Check out our free webinar. I will see you in the next video. Thank you. Goodbye.